Hello, it is March the 30th. It's Matthew Holt. I'm here with THCB gang back again on a Thursday afternoon. You might be listening to this later on the podcast, and I have a great lineup. And thank God this time I've managed to extricate myself from the overabundance of Y chromosomes I've had on the last couple of weeks, and have a great lineup of guests. So we have sharing one of those terrible chromosomes, Michael Millenson from Health Quality Advisors. But otherwise, Jen Benz from Siegel Benz, HR expert and communications expert. Jen Goldsack from the Digital Medicine Society. And our special guest this week is Sanjula Jain, who is the Chief Research Officer at Trilliant Health and also the host of the Her Story podcast. So we are on. Welcome all of you. Glad to be back on with everybody. Let's start the way we always start with a quick go round, and then we will introduce our guest Sanjula and find out a bit more about her and some of the many reports that she's done, but one in particular on mental health. So let's kick off. We'll get the men out of the way first. So Michael, quickly, what you've been up to? What have you been looking at this week?
I don't know if I got an intro today. Well, I was thinking about this, and I think the man of the week is Barack Obama, and the reason is that. On the one hand, he got us the Affordable Care Act, which is great. On the other hand, he really didn't get around to meddling in state politics. So we have 10 states still that have refused to expand Medicaid because of the GOP-dominated legislatures. And, appointing federal judges is also sort of a, pain to have to worry about that. And so we have a judge in Texas 13 years after the passage of the act, saying you can't give free preventive care. So Barack Obama's legacy, for better and for worse, goes on, not to mention, of course, the way his election permanently changed race relations in America, but we won't even go there. So just from a healthcare point of view, I'm afraid that former President Obama's legacy, for good and bad, lingers.
The lingering Obama. Well, he's been hanging out in Sydney, Australia, enjoying himself. So I'm not sure I have to worry about that. Jen Benz, tell me what you've been up to, what you've been looking at.
Well, on that Obama topic, did you see he got a lot of credit for that Wyoming law that was put in place to keep the Affordable Care Act out of people's business? And then a judge cited it to keep abortion legal. That was Wyoming, right? So
I didn't see that.
Yeah,
I hadn't seen that, but
we don't get a lot of Wyoming news on THCB gang, but Jen's studying up.
That's what I'm here for, my territory. No, that I saw that in the headlines on Instagram, so can't verify its accuracy, but there was a lot of credit there to that law. So the thing I've been keeping an eye on this week is I was at the Transform conference earlier this week in Las Vegas. It's a relatively new event. It started just a couple of years before COVID, and I think this is the second year that it's been back in person. Very well done. As one of my friends there said, they didn't entirely hate it. So that meant it was a really, really great conference. But what was very interesting to me is, we've been talking a lot about how all these really in the weeds HR topics are making headlines and getting a ton of interest and a ton of funding. And they had Jeffrey Katzenberg, like the Walt Disney Jeffrey Katzenberg, Little Mermaid, all that, talking about his new company that has funded a leave administration company and then a global payroll company. So they had Jeffrey Katzenberg on stage talking about the in the weeds details about how difficult it is to administer leave across different states and different municipalities. And I was speechless. I'm like, it used to be hard to get heads of HR to care about this stuff. And we have Jeffrey Katzenberg talking about it on stage at this conference. So that's my what's been keeping my brain occupied this week.
Wow, it's good to see Hollywood types getting into that. Did I tell you about the conference I went to in March 2000, where I met Eric Idle's personal assistant, the Monty Python guy, and she was starting an e-health company in March 2000. That was when I know the market was at the top. Anyway, Jen Goldsack, you guys have news this week. What have you been up to? You've been causing yet more trouble.
Only the best possible kind, but yes, we have. So I was also at a conference this week. So I was at Vive, and I think there are two really important things, at least.
Are the Black Bros still together? Were they happy?
I couldn't possibly comment.
You didn't even go to the most important thing they had there. No, Jimmy Page. Okay, go on.
So, I mean, I think we can't overlook the fact that, Vive was in Nashville this year, and on Monday we had yet another school shooting. We lost another 3 kids that we didn't have to, just while they were trying to show up and be educated and learn. And, it's a healthcare gang. And we have to think about the gun violence issue as a really important part of public health. And we can't just keep sitting through these things. So it was tough being there on Monday, and it was, fantastic to look around and see all of these innovators. And we, if we can't get the legislation we need to protect kids when they go to school, we need to think about other ways to do it. And I hope we can start to use different types of innovation to do that, whether it's geofencing or whatever it looks like, but we've got to get it right. So that was the really tough part of this week. The good news, a big announcement out of our organization, the Digital Medicine Society, is we're partnering with the Moffitt Cancer Center to co-host Cancer X. So Cancer X is answering the call of the White House, part of the Cancer Moonshot, to reduce deaths from cancer by 50%. Cancer X is a public-private partnership hosted by DiME, Moffitt, and with our government colleagues to provide that big tent home for everyone who's sort of innovating in digital health. And has innovations, has visions to be able to help achieve those moonshot goals. We're going to be the home to do that. And we launched with a project on using digital innovation to improve equity and reduce financial toxicity. And that's how we're starting, and that's how we need to go on. So an awful lot of work to do, but a great opportunity, and really excited about our ability to deliver on that.
Matthew, could I jump in?
Sorry, go ahead, Michael.
Because I was at the Highland Park shooting, as you know, last year on July 4th. And the local connection was there was a woman who was at the Highland Park shooting, and her son, 6-year-old son, was incredibly traumatized by it. And you may have seen that if you were down there. And she happened to be in Nashville to visit another woman whose son had been killed at a different mass shooting when this one took place. And she said, how American is that to be at these places? And it's just terrible. And it's the assault rifle thing without question that makes it so fatal for so many people. You really don't have to be a very good shot if you're spewing out 100 bullets a minute.
Yeah, on undefended targets, of course.
Right.
And it's just recently that gun deaths have overcome accidents as the leading cause of pediatric deaths. So yeah, it's just fingers crossed something will happen. But I'm sorry, it's been nearly 25 years since Columbine, and this stuff is now a regular occurrence.
And after it, to show where the Republican Party has gone, after Kennedy was assassinated, it was a no-brainer to ban assault rifles. Not anymore. Anyway.
Jen, before we get to Sanjula, can I ask you, so for the Cancer X moonshot or what it's doing, what's the role you're playing?
So we're going to DiME in partnership with Moffitt are going to serve as the hosts. So the way it's structured, Matthew, is that we're going to have a series of pre-competitive evidence generation projects where we essentially define what good looks like as we try and harness the power of innovation to reach those goals of the moonshot to reduce deaths by 50% from cancer. Then we're also going to run an accelerator cohort. So as we think about not only what does good look like in the digitized era of healthcare, and how can we use all of that promise from reduce the burden of cancer for all people, can we support fledgling organizations to be successful in implementing those new practices? And then the third piece of it is demonstration projects. So can we then give an opportunity, can we create at scale opportunities for those young organizations who can pick up these new best practices to implement them, so we can show, not just tell, that these new approaches actually work, actually save lives, actually sort of reduce sort of late diagnosis that we know are, catastrophic, both, in terms of clinical outcomes, financially, the whole thing. So, it's a highly structured approach, but we believe that's what it needs to be. So we're going to be sort of hosting all of those organizations that come to the table to tell us what evidence needs to be generated, to help us focus those cohorts and to, host that accelerator, and then to create those opportunities for at-scale demonstration projects.
Fantastic. Sounds great. And I'm glad someone's picked up the mantle so I don't have to do this stuff anymore. So Sanjula, so nice to have you on THCB Gang. Thanks for coming on. So tell us a little bit about, I know, as I said, you host a Her Story podcast. You've been obviously sort of in the mire in DC in terms of the politics of all of this, but also you're a data wonk. Working with a company of data geeks. So can you say a little bit about what Trilliant Health does? And then let's dive into the recent report you did on mental health, because we spent a lot of time talking about mental health and the digital health aspect here on THCB Gang. We'd love to hear, you have some data and some evidence, which, we don't bother with here. But tell us a little bit about your role at Trilliant, and tell us a little bit about what Trilliant does generally before we dive into that.
Yeah, well, thanks for having me on. This is really, a great discussion. And Jen, just, before I jump in, I have to commend you for the oncology initiative that you all are doing. Back to the data part, I've been studying some early trends already showing that there's going to be a market shift in what the oncology population looks like in this kind of post-pandemic health economy. So kudos to you and the team for really thinking ahead, because we certainly need that. So Matthew, to answer your question, so I'm a health economist by training. I am an academic geek. I'm, part-time faculty over at Hopkins. I like to write books and, think about, healthcare trends. Unlike the rest of you who are probably really good at solving problems, I'm the person who helps kind of surface problems and think about what are the trends that are evolving or emerging that we need to be thinking about as a healthcare ecosystem. And so I like to connect dots from all vantage points. So not looking at trends just from the perspective of a provider, but also from a payer, pharma, policymaker, and trying to bring kind of a unifying perspective. So at Trilliant Health, really it's an opportunity where I get to, it's like the academic's dream, right? I get to do academic grade research in an industry setting, which allows me to generate more real-time insights. So one of the reasons I left academia was that, as you all know, a lot of the papers that are published use data, think about COVID studies. A lot of it was, you'd read something in 2022 and then you'd see data from 2020 or, early 2021 at best, or it was only surveys on, really small samples. I have the great privilege of working with this treasure trove of data, which is basically a national all-payer claims database that's updated monthly. So I'm able to see real-time pretty much any billable interaction between a physician and a patient across America, regardless of which provider organization, if you're a health system, if you're CVS, regardless of pay type. I basically can see that on a de-identified basis, which basically, if you kind of do the math, brings you to about a sample representative of 300 million American lives. And so that is kind of a great privilege and a resource that my team and I have. And so what we really do is spend our time working with that data set to explore any number of health services research related trends, from telehealth to Medicare Advantage trends to behavioral health, which we'll talk about. And I'm constantly sourcing ideas and questions from conversations like these. So that's kind of what I do. The company at large, really, we do a lot of, our mission is to enable evidence-based strategies using data at the center. So we leverage that same data set with a lot of great machine learning and analytic approaches on top of that to answer very specific business and strategy questions, so that we can equip busy stakeholders to actually make real-time decisions backed by data, not so much about anecdotes. So, it's really fun and never a dull moment, as you can imagine, because there's so much happening and so much change at any given moment. And that's a little bit about what we do.
That's fantastic. Funnily enough, I'll have an interview up with Anish Chopra from Care.
Yeah, there you go.
Same sort of thing, and he was those of you who know Anish, he can be a little bit enthusiastic, and he got very enthusiastic when we started talking about AI and the potential of that for to change, not only the healthcare experience but also the data analysis game. And apparently ChatGPT-4 will make me an expert programmer, even though I've never even done basic. So it's a wild what we're doing. So let's talk about the report you came out with relatively recently on mental health. We've had on the show and on THCB, and Jen's nodding because she's had every one of her clients has been through this mill, and all the digital health mental health companies have seen tremendous growth and all the rest of it. But you actually have some data about it. So what were your conclusions, and what did you look at, and what were your conclusions from the data you surfaced?
Sure. So just maybe a little bit of context, because I know the behavioral health research space is really crowded and there's a lot of different studies and data points out there. So the purpose of this study that my team and I undertook was really to help. The central question was, how did Americans change how they received or accessed behavioral health care kind of throughout the stage of the pandemic, right? So are we doing something different today than we were kind of pre-pandemic? And what might that signal about the opportunities going forward? So the starting premise, there's no question that we have a behavioral health crisis in this country, right? We have not only more adults being affected, but the youth of this country, it's just skyrocketed. And that is a huge issue. And we've seen that reflected in some of the policy initiatives recently around proposals to expand screening for adults and children. We've seen some of the DEA rules around teleprescribing. So that's all kind of a given point. And so this study was not really intended to put out numbers about what the prevalence necessarily of the behavioral health crisis was, but it really was to look at that longitudinal behavioral health journey from a supply, demand, and yield perspective, right? That's my health economist kind of coming out. So what are some of the demand, consumer utilization trends, but also what are we seeing on the supply side? So, right, digital health was a big component of that. Did we see shifts in kind of what type of physicians were treating patients? And so took all of that together to kind of see what we thought was interesting and put together a series of trends. And so there were a lot of interesting findings. Once again, we reiterated that demand exceeds supply. No doubt there. We've been talking about the shortage of behavioral health specialists in this country. There were a lot of interesting findings. I would start with maybe one of the ones that really got me thinking personally. And I think it was interesting to see in a couple dimensions that because of that supply-demand mismatch, we're seeing primary care absorb more and more of that behavioral health care demand. Now, at face value, that probably doesn't sound as novel because we've kind of had that assumption before in the integration of primary care and behavioral health and all of that. But as we start thinking about the role of telehealth and virtual care and the rise in e-prescribing, we see more young adults and children, the rate of mental health prescriptions is steadily going up, is that we're seeing a lot of this prescribing activity also come from primary care. And so when you start peeling back the layers, kind of the question, and I'm not a clinician, but my question is, are we delivering the right level of specialized behavioral health care services for some of these behavioral health conditions, right? So if you have anxiety and depression, what is the recommended treatment and therapy plan? And are primary care providers equipped to treat that or not? That's one question. And how does that differ from how you treat youth with eating disorders and ADHD and some of the more specialized conditions? And I don't think we've really had that conversation in the industry of, even though we have a constrained supply, how we are trying to meet this growing demand. Yes, virtual care has kind of provided some more access in some ways, but it's not like the virtual care solutions have necessarily grown the number of psychiatrists and specialized behavioral health care providers we have. So it's kind of interesting to see some of these dynamics shift. And is that right or wrong? That's not really my place to comment, but I do think there are some interesting nuances within that are worthy of unpacking, particularly even from a policy perspective. And I'll just give one other example and then I'll pause. One example of that sub-trend is we see that there are more prescriptions for Adderall than there are ADHD diagnoses, right? So it once again kind of frames this question of, we may be prescribing Americans certain therapeutics, but are we also are they getting that prescription from an official diagnosis where they're getting, kind of screened and assessed by a specialist, right? And that's an unanswered question. So I think some of those mismatches and signals suggest some interesting things that are going on. So Matthew, there are several more findings in the report, but let me just pause there and let folks react.
Can we dive into that one? Because this is one that if you've been on THCB, you'd hear me whine a lot because my kids are among those frequent, folks who have been diagnosed with ADHD, and getting hold of the Adderall has been a real pain in the rear. And there is definitely a supply shortage. So there's a lot of questions about, I would say two things. One is how much, ADHD and other diagnoses among kids and adults have increased because of the pandemic. how much they were just undiagnosed or not diagnosed before. And then the next question is, what's been the impact of virtual care in terms of sort of increasing those diagnoses and those prescriptions? Were you able to tease out any of that from the data, or I mean, what level of specificity what can you answer for those types of questions?
Yeah, so I'm terrible at memorizing numbers, but just to kind of give you a broad stroke starting point. So when you look at prescribing for Adderall, right, across all age cohorts, we saw the greatest growth for adults ages 22 to 44, right? So that's just kind of one interesting data point. When you look at kind of the visits rather, right, like the number of people, getting treated, going to see a physician for ADHD, what's interesting is some of those trends were starting to materialize before the pandemic, right? So you saw, 22 to 44-year-old visits were, going up a little bit. They were starting to, going down a little bit for that under 21-year-old age cohort. And the prescriptions were suddenly rising, even before the pandemic. And the pandemic kind of accelerated a lot of this, right? So like I said, I want to be careful to explain what could be driving that, because I'm not a clinician, right? But I think there are things where even as a society, right, like we have this consumerization, digitization of healthcare and evolving consumer expectations. Like I think we've seen, whether it's in antibiotic use, most recently now with the Ozempic use, right? We have a little bit of this behavioral trend towards, I think consumers and patients might be, saying, I think I want some of these medications, right? I'm not saying that's all of what's driving this, right? But I think there are some dynamics that are really hard to measure in this data. But the fact that prescriptions don't necessarily align with diagnoses is concerning, right? Because it's like, who is making the call to determine whether or not a given patient should get a prescription? From the virtual care perspective, the best data point I have for you is to look at stimulant prescribing at large, so Adderall and other stimulants. Generally, before the pandemic, we saw prescribing via telehealth for stimulants was less than 1%, makes sense. Today, it's about 40%, right? So it's a large share of prescribing activity that's happening there. I'm sure there's a lot of that that's been made more convenient and accessible, but with anything we see, I'm sure there's also a subset of that share of prescriptions that maybe are not as warranted, or maybe did not go through the same level of scrutiny, and that's also contributing to a lot of the supply challenges that patients who really have a documented clinical need, that mismatch of who's actually getting the prescriptions versus not.
Are you seeing any change in the most recent data, given that Cerebral and some of the other online companies were heavily involved in that shift and have now stopped doing some of these ADHD diagnoses and Adderall?
No, we have been looking at that. So before a lot of that Cerebral news actually became public, we had actually published a preview of this study, I guess, however many months ago before that. So we were kind of tracking that. There is not a significant enough dip to attribute it just because of one company, right? But we are kind of tracking that. So the utilization and those trends are still very much there. And I think there's still enough other smaller players out there that are contributing to it. But it'll be interesting to see over time, less so because of the, cerebral, but I think if this DEA policy kind of goes through and creates an additional layer there, I think those are some of the things that could create some shifts.
Yeah, and we've talked enough about that on the show. We actually one of our regulars who's not on this week is John at Neptune, who runs a substance use disorder online clinic in his spare time, well, his day job, and he's been very cogent, sort of sanguine about the whole question of banning Suboxone. Did I say that right? My knowledge of drug names is terrible, but I think that there's and I'm one of the people who's commented on both on that and on the DEA issue of accessing drugs, but it's a significant problem, and I think one of the things that is going to continue to be a big issue, and we'll talk about this in some of the digital health ramifications of this, is that you still have prescriptions over here and medical care over there, and there's still barriers to getting to them. Even if it's you have to get a prescription, have to go to a pharmacy, you have to find drugs, and we do know that in any event, irrespective of condition, multitudes of prescriptions that are written don't get filled. They get picked up, and I think that's, you may have better numbers than me. That often has been quoted around 30% or more. So you're, how we're dealing with the kind of stuff that Jen has to deal with every day, in terms of managing the care process. It strikes me as being can get revealed by these numbers in a big way. Were there other, and then Michael, do you want to jump in?
I was wondering whether, essentially, you saw the investigative piece that Stat News did about the origins of the PHQ-9.
I did.
Which was a great piece that talked about how it was, a marketing kind of thing for Zoloft, and then it took off, and all, of course, and it makes it easy for the primary care guys to prescribe, because I gave them a questionnaire, and there it is. I thought it was a wonderful revelation of what, history that I'm sure most of us had no idea about. And then, interestingly, I was having lunch today with a friend whose primary care physician is double boarded in internal medicine and psychiatry, which was sort of unusual, and decided to leave internal medicine and set up a psychiatry practice, probably because of the demand and supply kind of thing going there, and all the rest. But the Zoloft thing was pretty interesting.
Well, so I'm so glad you brought that up. The day that came out, I forget how many days in, we had just released our report. And so I was like, oh, this just connects the dots even more, because one of the conclusions of the study is basically, okay, so play this out, right? We already have the supply shortage. There are these recommendations on the table for additional screenings, right? And so wearing my public health hat, right? Okay, well, screenings are good for prevention and detection and all of that. So yeah, you're probably going to catch, some individuals who really do have those conditions. But with everything, as our CEO always says, the system is kind of working the way it was designed. And so you really think about, well, more diagnoses is then going to lead to everything else that comes with that. And without even that in place today, what we're seeing is that the total cost of care is already increasing, right? And so then you add the fact that you have a younger generation of Americans who are starting behavioral health prescriptions and treatment earlier on in life than they ever have before. That's going to compound over time and then correlate with other physical comorbidities that they're going to have. So to me, that screening is going to create additional healthcare costs and needs and services, some warranted, some not. But it made me think back to that PHQ thing, right? Well, what are the appropriate screening tools, right? And have we really revisited, like I said, I always have the preface, I'm not a clinician, but right, like we should almost take a step back and, are we screening the right way? Have we equipped our clinician workforce to think about it in the right way? Who's driving where are the incentives, right? With anything, there's always someone kind of driving an agenda somewhere.
We decide more screening with a tool that was designed by a drug company, and we put that on top of clinicians who don't have very much time, and the incentive. And of course, we know that patients, you did something for me, you prescribed a drug. But the analogy that I was thinking of is sort of goes to Cancer X as well, is cancer screening, right? That screening must be good, right? So even though we know something about pap smears, or we know something about prostate cancer screening, so what? I should get it every year, or I should get it, twice or whatever, right? And more screening is good. And so therefore we catch anything in the false positives. And thank God we have MRIs to refer people to, which is, and there we go. Right.
But then also combined with the overscreening is, I think, kind of a cultural thing of, well, you have to take the most aggressive approach to correct anything that is, anything that might be there. And we see that with cancer, but is that similar with mental health, where there's any sort of, possible diagnosis gets everything thrown at it?
If it's your kid, wait a second, is it for me, which I don't care because I'm a guy and I don't pay attention anyway, but it was for because guys don't get sick. But if it's for your child, then, the possible diagnosis, are you going to let your child not get treatment, right?
Well, I would go further, speaking as a parent of kids who have this, is that, I would, look, I'm British, so we have the stiff upper lip. No one ever went to therapy. I literally saw last night, Jen will appreciate this, Jen Goldsack will appreciate this. I saw the 40 Towers episode in which the psychiatrist comes to stay with Basil Fawlty when John Cleese, and she's laughing at it because she remembers it, because every British kid has this indoctrinated into them, where where John Cleese is acting crazy, and as soon as he finds out the guy's a psychiatrist, he's terrified of what he's going to tell him. But in general, we haven't talked enough about mental health as a society, right? We haven't done it, and now it used to be just Woody Allen going to a therapist in the sort of 60s and 70s, and now it's a general conversation. So you would expect, like autism and like some other conditions, to start thinking about, yes, we were undiagnosing these. On the other hand, as Sanjula pointed out, are we overdiagnosing them, and are we giving people treatments for stuff they're not diagnosed for? I would say that in my N of 2, those pills help a hell of a lot in managing a family, getting kids to be able to do their homework and work, and where there were real problems before, and they were, in our case, definitely highlighted by the pandemic and all the stuff that happened. And I'm not surprised that this is, the way it is. And honestly, I kind of go back to the fact that in the 50s and 60s, you used to beat your kids, and now you medicate them. Neither are great outcomes, but you still have to. They still have to go to school and survive, and all the rest of that. And we know that what we used to do for people's mental health wasn't particularly great. But it just to sort of square the circle, Jen, I'd be interested in your point of view on the possibility of using digital health to extend the supply side. I keep on seeing, I sat through the What If Ventures, which is a very, very early stage sort of accelerator for mental health. I sat through their thing, and there are yet another 2 or 3 of the sort of 20 pitches where they have kind of an automated therapist doing CBT and trying to figure out to get around the fact that there aren't enough psychiatrists, right? There aren't enough psychologists. We cannot make them fast enough. There's no way we can do that. So either it's kind of pills, or maybe it's a digital therapeutic that is early days, or maybe it's one of these automated AI therapists. And 10 years ago at Health 2.0, we had something called Ellie, which came out of the USC lab, which was an automated therapist who was sort of tracking people's movement and eye and tone of voice, and then responding to them. And it was supposed to have pretty good results. And now we have things like Wobot and other text message based systems. You can imagine that with a combination of automated CBT, avatars, AI, all the rest of it, we might be getting closer to getting better in that world and dealing with the supply. Jen, am I talking rubbish, or are some of the companies that you associate with getting there?
So, I mean, absolutely. And I think that's...
I'm usually talking rubbish, but in this particular case.
No, I think you're absolutely right. And I think what we have to look to virtual care to do, or virtual first care, is to figure out how to extend every unit of clinical expertise we currently have, how to extend them, and how to overcome the maldistribution between where those clinicians exist and where the patients who need them are. But I don't think, I think we almost have to look at these things as sort of triaged, and it's not an either or, it's a yes and. We must never lose the psychiatrist or the, clinical psychologist or the, primary care provider, but we have to think about when might it be appropriate to use some of these AI tools. And, quite frankly, some of them are getting really good. And, we haven't said the latest buzzword yet, ChatGPT, and, all of these sorts of, new tools that are, the generative AI, all of these sorts of things. There's an argument that they can be quite effective. There are the digital therapeutics now, lots of CBTs that are proven to be very effective indeed. But there are still going to be cases where we need traditional molecular therapies, where we need a clinician to do the more traditional talk therapies. And so we have to be taking a yes and approach, and we have to be doing our best to triage individuals as early as possible into the most effective pathway to them. But, one thing I would like to pile on with, as we talk about, this, are we overprescribing, are we overscreening, this, that, and the other? None of this is new, right? I mean, Matthew, your favorite topic of late is lower back pain, right? I mean, we know this to be true. Like,
I'm all better now, so I don't feel like you're
I'm fine. But, what no physician ever says is, you need to lose 5 inches off your waist and stretch your hip flexors. Instead, what they say is, I want you to feel like you've been heard, so we're going to send you for an X-ray because we have to. Completely bloody pointless. And then you're going for an MRI. No one wants to be sent to physical therapy where you actually have to do the work. This is a sort of a facet of what we look to medicine for. And the challenge is we're in a resource constrained environment. And so there's an endless battle and there's an endless sort of scuffle over all of this. And Sanjula, to your sort of point and to your data, where is the greatest supply side constraint right now outside of dollars? It's in, the capacity for us to provide good mental health care. It simply doesn't exist. So Matthew, to go sort of full circle on your question, not only is this exactly what virtual care has to do, there are definitely some very, very effective examples of this already happening. And I think we have to embrace it.
But Jen, I guess maybe a question / comment. So I agree with you, right? Like that whole, to me, that's the consumer American way of things, right? Part of this is like that, to all the examples you said, that's a lot of what's probably happening. My naive hypothesis going into the study, right, was like, okay, well, more virtual care supply. So therapy, right? Like all the more, we're going to see more of a shift towards therapy, but like anything, therapy is also work, right? It's not the quick fix. So how do you see digital health, like some of these solutions you're describing? A lot of them are focused on therapy and some of those, non-medication therapeutics, but do you think that patients and Americans will adopt those back to these ingrained behaviors that we kind of have as a society?
I would be getting over my skis if I made big, bold statements about what Americans might or might not do, although I am half American, so I'm very proud of that. But I think it goes back to, therapy also requires a clinical care provider, and there aren't enough. And so one of the things that I think digital is doing very well is it's not just, doctor software where we're relying on sort of software as medical device solutions or AI solutions, but the whole full stack solution actually allows us to harness not only new technologies, but new members of the care team. So we're seeing things like health and behavioral health coaches. We're seeing things like peer support coaches, where individuals are being trained, whether it's in the recovery community or actually the VA does this very well indeed. They have tremendous peer support coaches to support their behavioral health programs. And I think that what these tools allow us to do is take a much more creative and fit for purpose approach to provide the individual with exactly the care they need when they need it. Now, we're not ready to fully turn on that hose yet. We can't, connect everyone with exactly the right culturally sort of competent care that they need today. But I certainly think that's what we should be driving to. And, the data that you're sharing is the imperative for that, right?
Can I pose I'm sure an unpopular question to the group that I was just thinking as you were talking, Jen? So one of the things we see in the data, right? Of course, we've seen this rise in more Americans, younger and older, with these mental health conditions. But a lot of that, when you look at the actual specific codes and sub-conditions, right, they're mostly stress-related adjustment disorders, right? And that makes sense, right? COVID turned everything upside down. We forced children to not socialize, go to school, and sit at home and be behind a screen, right, in their peak developmental years, right? We as adults had to adjust to doing this, all via Zoom and figure out childcare while working busy jobs. I mean, like there were so many things about the pandemic, societal, environmental wise, that explain why we all had this marked level of stress and adjustment. And I think that's a large contributor to what we're seeing. And so I'm kind of wondering, as the world kind of opens up, right? We're traveling to conferences we just talked about, right? People are vacationing, airports are busy. We're not all necessarily going back to see our docs and doing things like we will, but do we think that there will be digital health solutions or other solutions that will potentially like mitigate some of those original stressors that kind of cause some of these conditions? Or is this going to be a lifelong thing that follows, our society now? Like I said, I know it's slightly of a clinical question, but if I think about the root cause of some of these, new cases, I feel like we don't talk enough about that also in this country.
Yeah, I can jump in. I've not that I have all of the solutions here, but I've been thinking about this a lot because I think collectively we all went through this very traumatic and very stressful period. And kind of coming out of that, it could look very differently. But what we also saw is a real reprioritization of where people want to put their time and attention and energy. But then we're kind of sliding back into those old habits. And so I think that in of itself creates more stress, because it's kind of what you want to do or what you saw was a different way versus what is being demanded of you by capitalism and employers who are now demanding you to go back to the office 5 days a week for no real reason, or the work travel that wasn't really healthy before, but is now kind of coming back. And, all of these things that we kind of had a moment to reevaluate, and then we didn't really make long-term changes. So I think a lot of that stress is going to continue, because now we're still in stressful scenarios. The cost of living is very stressful. People's financial situations are not getting more stable. We know that finances is one of the biggest causes of stress, and financial issues and medical issues are so interconnected. So I feel like we kind of have this whole bundle of a mess that is American healthcare and American financial security, combined with jobs that are not really built for humans, and that it's kind of no wonder everyone is stressed and has mental health issues going on. And that's a very pessimistic response for me. But
Jen, in the surveys of the large corporations that were done by Mercer's, Towers, Perrin, all those folks last year, year before, they all said they were going to prioritize mental health. They were going to dial back on increasing deductibles and copays, which frankly was just cost shift, nothing to do with utilization. If there's a copay for the ambulance, do you say, well, you know what? I think I'm going to walk to the ER. That's okay. So the question is at least for the large employers, which are only a segment, have they prioritized mental health? Do they in fact try to help people get actual help as opposed to just here's a diagnosis and a prescription? I mean, some of them are pretty sophisticated. The question is whether they use that sophistication.
Yeah, I mean, there's some really, really great solutions out there, and employers have put a lot of money towards trying out the new digital health companies and the virtual care companies and so forth. And they've tried a lot in terms of flexibility and manager training and putting in more time off programs and more generous leave programs and things like that. So I do think in terms of the HR programs, employers are doing a lot, and they're committed to continuing to doing a lot. Where some of that just falls apart, though, is a lot of your stress that comes from work is related to whether or not you have a good manager. And a lot of people have really bad managers, and that is a really unhealthy, stressful environment to be in. And what I think is really interesting is when you look at a lot of the talk about companies that are unionizing and a lot of the examples that they give as to why specific locations are doing that, a lot of it comes down to bad frontline managers. They're not bad corporate policies. It's bad decisions by inexperienced or ill-intended managers.
You should be my boss. Go on, Michael.
You mentioned, I was thinking, even though Scott Adams has now been exiled, what he did do very well with Dilbert is capture the world of those of us who have worked in a cubicle. And I like to think that, members of Congress, they've either owned their own business or they've been a corporate lawyer, so, how many folks have experienced the capitalism of working in a cubicle, right? And I've worked in cubicle world, and it's not like the economics textbooks. So a lot of people who propound on these things don't know. And I think that is part of the stress, who your manager is, or they've now taken away privacy, right? You used to have a cubicle with a little wall on it. Well, let's be all open, even though, of course, that takes away things where people put on their headphones and everything. And there's a lot of lack of sensitivity to what real life is like, as opposed to whatever the latest corporate trend is that increases stress.
Yeah, and I have two things. One is we know it also it flows downhill, right? It's worse at the bottom if you're in an hourly paid job, and
yeah.
Ian Morrison said to take the early bus. Your life is definitely tougher. We know for years. I mean, that British civil service study from I think the 70s and the 80s, looking at the level of stress as you go down the rankings in the civil service. up a little lower. And the other thing is that, I mean, I used to have this joke, I think must be about 12 years ago, when I gave a talk at the Oregon Medical Society, and I had been giving them a talk, I think 10 years before. And I came and told them, this is what I told you was going to happen 10 years ago. And then I went through like the history, and I think it started with the Monica Lewinsky, Bill Clinton thing, and it went to the 9/11, it went to the Gulf War, and it went to the refugee crisis, and it went to, and it ended up with Trump, right? So all this stuff that happened. And now you could add Trump and Brexit, and you could add the pandemic to it. The level, I think, of external stresses for people in developed countries over the last 2 decades has probably picked up quite a bit. I mean, I'm not saying it was all sun and games and everyone dancing around to ABBA in the 70s and the 80s, but, I obviously went through oil shocks and there was recession and what have you. But I think, that compounded with social media, which obviously is a big part of this, and obviously, those of us who were at the beginning of that thought it was a great thing, and it's now been proved to be pretty rough on everyone's psyche, and compounded with the greater availability of drugs, but also this greater social, okayness to talk about it, has kind of got to the problem that Sanjula was documenting, right? Which is that we have this increasing demand. We don't necessarily have good supplies or good answers. And by the way, a lot of the drugs we're giving for this stuff aren't very good. A lot of the antidepressants and what have you, the SSRIs, and don't particularly work well. The Adderall stimulant class are stimulants, and they are addictive. We're going to be careful of them, and there's lots of problems with all of this. And it does worry me a lot, and I am hopeful. All being said that we talked about the problems getting people to use the stuff, and I'd like to hear Sanjula's sort of point of view as she's seeing any of this come up in the data. But I'm hopeful that some of the digital tools that are sort of coming, both the AI based, some of the even things like the Headspace and the Calms of the world for meditation, that some of these tools actually can make a difference, right? I've had a couple of ones I've looked at who've tracked heart rate variability, and the ability of people to control that, it does reduce their stress. It reduces their numbers on the PHQ and on the GAD-7, which even if they are, even if they were set up by drug companies to sell more drugs, I do have some indications. And there's even now a series of sort of these biomarker tools, which aren't quite ready for prime time, but by listening to your voice or whatever, going to start diagnosing and telling you how you're doing, and get a much better, more accurate reflection than occasionally filling in a PHQ formula every 6 months or what have you. So, I mean, there is some hope that there'll be some solutions coming out of the digital health stuff. But I mean, I suspect, Sanjula, you haven't seen it show up yet in the data, but I mean, maybe you have, maybe you're tracking this with your clients.
No, it's certainly early. It's a question we think a lot about. I think individual organizations with those solutions, they have little case studies that say, patients report, lower levels of stress. It's more self-reported data. I think for us to see if it's moving the needle at scale in the measure, right? It depends what measures you're looking at, right? When we look at the total cost of care, or will it have an impact on utilization, medication, some of the larger outcomes we're talking about, I think we're still very early in on that. But I think it'll be interesting to see that, I don't know how many years it might take for that, if that, but that's another question about what patients report of. It's like HCAHPS, right? Like, I'm satisfied, I'm going to return back, but then I still, I'm going back to see my doc and I have all these health issues, and I have, 5 chronic conditions. So I think it's a technical question of what are we actually measuring as success and effectiveness, but to see it at the scale from a health economy perspective, it would have to have some moderating effects on either, strength or dosage of medication, number of medications, use of therapy, overall cost of care, that kind of broader longitudinal journey. And I think it's just way too early to see that.
Are you seeing, I mean, we heard a bit from Jennifer Benz about, the role of it, and Michael, who you may not know, in his prior life was a Mercer consultant way back when. Have you, we heard a bit about employers caring about this stuff, and, how much can they deal with yet creating the environment that's bad for them? It's a bit like the Ozempic Wegovy thing, right? Where we have an agricultural and a food system that piles on the calories, and now we're going to give people very expensive drugs to stop them taking it. In fact, I saw a Wegovy ad in the background last night. I was in a pizza place, and it said at the big screen, average participant lost 25 pounds, and in tiny letters at the bottom it said, Wegovy is not a weight loss. No, sorry, it's the other one. Not Wegovy, the Lilly one. I forget what its name is. No, name is not a weight loss drug. And I went, funny that the big scene says you lose 25 pounds, and the small one says it's not a weight loss drug because people with diabetes talking about off-label prescribing. But I mean, are you seeing from the folks you consult on the provider side and the plan side, I don't know how much you get into this, a sort of different stance towards this, or are they kind of just trying to ward off with their individual issues or any of the supply or costs?
So to clarify your question, are we hearing different stances on what the measurement of success is, or like how
how they should be dealing with with the challenge of the increased sort of diagnosis and problems around mental health as a whole? I mean, you tell me this, I'm a big health system or I'm a big plan. What the hell do I do?
So it's interesting, right? I've been actually just being at Vive this week. We've had a couple of conversations on it. So from a traditional health system perspective, right, historically behavioral health as a service line, right? Like, once again, there's the public health lens of this, and then there's the running your business model lens of this, right? And how to keep the lights on. So health systems historically have lost money on behavioral health as a service line, right? So it has not really been an area of focus to the same extent that other conditions have been. I think that there have been a handful of more innovative leaders at systems that I've spoken to personally who have said, we now see the interlinking more clearly to other comorbidities, chronic conditions, the overall total cost of care, settings of care, that broader journey. So we're thinking about behavioral health care differently and how to reroute from, ED to outpatient, virtual care. How do we get them in to primary care? How do we move them more upstream? So, but that said, that's not the majority of the sentiment, at least from my experience in my personal conversations. I think all providers see this as an issue, but it's still a challenge of how do we as a system, what do we do to influence this trajectory? And so right now the focus has been about preparing for the future to say, okay, well, if this is really going to change what it means for other conditions and other clinical needs, we might need to approach this differently than we have historically. On the payer side, I think, we've kind of been talking about it indirectly. I think there's a lot of discussion about integrating some of these incentives for employers and groups to kind of cover things like Calm and Headspace and all of that to try to, provide these solutions. I'm of the mindset, I think there's still a little bit of a debate of how, it's another point solution. And so, you can facilitate access to a lot of these things, but is it going to first guarantee adoption amongst your patient population or member base? That's number one. And then number two is, within those who do adopt it, are they self-selecting in? Are they the people that need it the most? And then what is that help? What is that changing downstream, right? And so if we look at how a lot of these different businesses are incentivized, right, it still goes back to a lot of these common metrics of readmissions and total cost of care and, visits and number of medications, things like patient satisfaction and levels of stress and all those things are intermediate factors that matter greatly, but they only matter financially if they can move the needle on the things that we're all reimbursed and incentivized on. And so that's the challenge.
And I think that let's emphasize the incentives, Sanjula, right? When you said these systems are concerned because it's increasing the cost of care, I believe the other way of saying that is everybody else isn't concerned because it's increasing the revenue from giving care, right? So, hospital systems love to blur the line between we care about cost. Well, should I put money into the orthopedic surgeon or should I put money into the behavioral health social worker? That's a pretty tough choice for most of them. And when it comes to the health plans, there's a lot of let's just make this a carve out and we've met it. So I over the last few weeks, as it happened, I've talked to a couple of individuals who are very active in the mental health area, and they believe that what we need to do is really make sure that the parity law is enforced. Right, that the theoretical requirement for parity is actually enforced, because it hasn't been, and you need that kind of public thing, because otherwise people will follow the money, and the money is okay. Well, we cover mental health. We have 7 providers in your state who are available from 6 a.m. to 8 a.m. on days without vowels, right? And so we have to kind of make sure that we help good intentions be backed up with some good financial incentives.
Yeah, I mean, I also feel that we've had a lot of discussions about the mental health of people with chronic disease, because of these folks with diabetes and heart conditions, et cetera, et cetera. And, you've had any number of certainly digital health companies doing coaching and saying, well, you've got to include, I think Vida, for example, has been very aggressive. Stephanie Tonius there talking about how we have to, they will only do diabetes coaching if you also have mental health coaching alongside. And you can imagine, that will be something that these kinds of as we get more and more into people getting programs, and there are a couple of announcements I know at Vive this week and elsewhere about people doing sort of more encompassing programs. I talked with Glenn Tillman along with Anish Chopra just recently about the sort of the work they're doing in Transcarent, trying to make everything sort of, whether it's a mental health visit or a physician visit, encompassing it all in kind of a big navigation package. You won't call it navigation, but you can kind of see the sort of green shoots of these programs. And if you think about what the Kaisers and Geisingers of the world have done, they've kind of had these kinds of programs for a while around different conditions, but no one's really made this mainstream where we're going to take care of your physical and your mental health, even for people with chronic conditions, where if you can improve their mental health, their physical health will improve too and will lower costs. And as you said, Michael, it all goes back to the conversation we've had 8 million times on the history of this show and elsewhere about, what are the incentives to
So Matthew, as I've said to physician audiences as well, grab them by their wallets and their hearts and minds will follow.
But moving the wallet around is incredibly tough. And honestly, the thing that somewhat worries me about, when I now, especially, Jen will resonate with this in kind of the tough times for the digital health community, even if 7,500 people were prepared to pay $3,000 each to go to Vive or whatever the number is. The issue is it's very easy to say, okay, well, can I scale back what I'm doing and go and find a nice drug company which will pay me to have an adjunct diagnostic / therapy to the drug because they have money and I can afford this, rather than go and sort of face down, either spend the millions that Lyra and Headspace and Ginger and Spring Health and others have raised, to try to sort of get into the mainstream. And they've done okay. Or alternatively, can I figure out the way, can I go and sell this to your prototypical system that could either provide this to people or could make more money out of orthopedic surgery. And I think it's been it's going to be tough for them because, as I think both Jen and Sanjula mentioned, you haven't really seen these integrated mental health things sort of get to the mainstream and really move the needle. Even though you have got millions of people voluntarily using Calm Headspace, and obviously more than were before using virtual therapy, and even the ones who aren't using just virtual care just to get easier access to ADHD meds. So I see the good in this. It's really struggling to break through. And what worries me, going back to what Jen Benz was saying, right, is that you have these big employers who've been pushing all this stuff. If life gets tough in the next couple of years and we start having the recession that everyone says is going to come, and you start seeing the labor market get tighter, looser, I guess is the answer, right? It's harder to get a job. Does that stuff start to go away? Do the employers stop caring about that? I don't know. So my overall tone is I'm cautiously pessimistic, I think.
I mean, Jen, I think I'm hoping you can give us some insight on this, because my sense is, the majority of the workforce now sort of values a whole person approach to care and their benefits in a way that they haven't before. And that feels like a real driver that hopefully will be sustained to, retain the incentives and maybe even increase the incentives for these sorts of solutions to continue to mature where they already exist and continue to sort of incentivize new innovators to be able to come in. I mean, that's a little bit what I'm seeing from when I look at the sort of large employer space, and curious for what you're seeing with in your daily work.
I agree. I think there's been a real prioritization of a more future looking approach to healthcare, and certainly with mental health and other areas that need innovation. What I think is going to be interesting this year is there's going to be this huge sorting out of which vendors actually are successful and which ones aren't. And what we've seen is that in the last couple of years, employers have put in so many niche solutions, and those niche solutions have all kind of grown from what they were originally intended to do. So now they're overlapping in a bunch of ways that are very confusing for the user and maybe unnecessary in terms of the ecosystem of a single employer. So there's going to be a big shuffling of kind of who stays and who goes. And hopefully some of these solutions that are really making results are going to be the ones that come out on top, and then they'll continue to get market share and continue to prove out good outcomes.
Well, some evidence and some success would be great. So you're more optimistic than I am. I like it, Jen. Thanks. All right, we're very close to the end now, so let's wrap the way we tend to like to wrap. And Sanjula, I hope you can join in on this one. What are you looking for next in the next couple of weeks, couple of months? What are you tracking and think might be interesting? Michael.
Actually, a phrase that Jen Benz just used was sort of what I was thinking about: who stays and who goes, and not just in mental health. I think we're having a lot of who stays and who goes, a lot of folks folding or laying off people or consolidating. And of course, all you have to do is say the word AI and click your heels 3 times, and maybe you'll attract some new capital. So I think we're going to see a lot of that, and it's a good process. But it's going to be hold on to your seatbelt, as it were, process. Last thought, when you mentioned, Matthew, about some of the worries about behavioral health, I thought of long-term care, right? Something that we know is incredibly important, but there ain't no money in it, right? And that's part of what behavioral health has suffered from, to a lesser extent, but is that, do you want to be a behavioral health app that helps drug companies recruit people to clinical trials, or do you want to be the real potential of digital health, which is one to many, right? Which is really the breakthrough, and that's an issue. So I think we're seeing a lot of push-pull here, it's important that we surface that so that the folks who are trying to do good really end up with the money to do that and aren't sort of thrown over. So I thought it was a very thoughtful discussion this afternoon.
All right, Jen, one of the Jens, Jen G. Why don't you tell us what you're up to next?
So we're watching some of the new movement coming out of FDA. So for immediate effect now, medical devices have to prove that they're resilient against cyber attacks. So specifically having to sort of produce software bills of materials, so on and so forth. So I think that's exciting. It's also going to, challenge some digital device manufacturers to sort of step up and acquire those skills pretty quickly. There was also the draft guidance that came out, I can't even remember, today, on predetermined change control plans for AI. And so it's quite exciting to see the first sort of guidance come out that contemplates, a non-static sort of algorithm, so actual AI, out in the wild being used within medical devices. So that's exciting. We'll be tracking that. And then, of course, we will be recruiting furiously folks to the mission of CancerX. So proud and excited to do that, and definitely taking a big tent approach. So if folks are working in that space, join us.
Fantastic. Jen B.
Oh, there's so much going on with clients and different things that they're digging into. So I think mental health will continue to be a big topic over the next couple of weeks. And then I think too, there's a lot of interesting things happening on the gun safety topic, and I'm really curious to watch the reaction to that. And Jen, I appreciate you bringing that up at the start of the conversation, because it's such an important public health thing, and talk about something that creates unnecessary stress for people every day. So I'm really eager to see if this, the reaction this time around will result in some different policies.
Absolutely. And I didn't mention, I think that we now have, 2 decades worth of kids brought up with doing, lockdown drills at school and stuff that we would never have thought about Anyway, Sanjula, thanks. Such a pleasure having you on. What's your focus for the next few weeks? What's the next report going to be? What are you looking at?
Lots of reports. So every week I have a new study out, actually. So right now we're doing deeper dives into behavioral health that building off of the report. So kind of a two-part focus. One is the report right now really gives you that like broad view. We're working on a kind of a premium report that will allow you to kind of go specific to drugs, specific subcodes, specific provider groups to really see where the trends start changing. So is there a difference in, brand versus generic use on, within certain patient cohorts, and getting really granular? Are there certain markets that are seeing differences in behaviors, whether it's a supply issue or a demand issue? So excited to kind of unpack more of that in partnership with a lot of our partners who are wanting to really understand what these trends mean for their businesses. And then the second part is, I forgot to mention up front, I have access to another new part of the data set that we're going to start layering into a lot of the research. So as you all probably know, with some of the changes to the price transparency laws, now all the payers have to disclose their rates, and there are all a ton of files out there. It's really hard to organize and make sense of it. Lucky for me, I have a lot of colleagues who have expertise in data science and data engineering who can make sense of all of that. So I can now see exactly what different payers, from United to Anthem to Blue Cross, are paying in different providers by zip code for a specific procedure. So I'm going to be starting to play with a lot of that to see how that changes some of these cost of care analyses. And Matthew, you mentioned Anish coming on, right? We talk a lot about value-based care, and it's really value-based competition. And so how to start layering in the pricing data to see what this actually means for this longitudinal patient journey. So a lot more analyses to dig into in the coming weeks.
We could just start talking about Medicare Advantage and risk adjustment, but we don't have another hour, so we won't do that. All right, fantastic. Well, look, this is a really wonderful discussion. Thank you so much for all of you for coming on. You have been watching or listening to Michael Millenson from Health Quality Advisors from the stable Midwestern city of Chicago, Jen Benz from the weird place that is San Francisco, which is getting better or worse depending on who you follow. Jen Goldsack from the hellscape of Florida, which is getting worse. I don't care what she says. And Sanjula Jain from Trilliant Health, based in DC, where all great things in America come from, I think. Is that correct? Close enough. Anyway, this is Matthew Holt saying you've been listening to THCB Gang. It's our March the 30th episode. Thanks very much for listening or watching. We will be back with you with another THCB Gang next week with a different cast of characters. And I hope to have some of these same folks on. And Sanjula, hopefully we can get you to come back at some point. Okay. Thanks so much.